Hi, thanks, Jeremy, and welcome everyone this afternoon. So I'll be talking on an update on diabetic foot infections, and it comes amongst a couple of papers that were published in the last year or so. Firstly, the IDSA and the International Working Group for Diabetic Foot have released an updated and consolidated guideline. And actually, just before that, there was a great state-of-the-art review, which sort of also did a synthesis of all the evolving evidence in this realm. So we'll get straight to it. So the starting point is this: diabetes prevalence. This is from a paper in The Lancet published last year. It's data up until around 2021. And this is a heat map essentially showing diabetes prevalence across the world, the various hotspots. As you can see, the North America, particularly certain parts of North Africa, and South Africa, you can see where we are actually, according to this map, around 6 to 10%. But in reality, at least based on data from up to last year, we actually sit closer to this, around 12% diabetes prevalence. But much scarier is this from the same paper. This is essentially based on the increase in prevalence over the last 60 years, projected increase in prevalence. And basically look at the end here, by the time we get to 2050, worldwide prevalence will be around 10%. Now, based on population growth, that suggests that there'll be approximately or just under 1 billion people living with diabetes type 2 in 2050. Now, the problem is relevant to our talk that up to 34%, up to around a third of these people will suffer from a diabetic foot ulcer, diabetic foot manifestations, and a third of those wind up having an amputation. And that's what we want to avoid. Obviously, amputations come a long way in the last couple of 100 years. I think the unifying factor in all the old artwork is how many people it takes to hold someone down when you're chopping off a leg with no anesthesia. But even with all the technological availabilities we have today, survival of diabetes patients with a major amputation is comparable to malignant disease. And I'm going to show you one or two graphs suggesting why that is. And notwithstanding the mortality outcomes, there's the physiological component. Movement suddenly becomes much less efficient. That has effects on one's metabolism, longevity, major economic and psychological effects. And this is really what we're looking to avoid. So while us as the ID proponents swear by source control being the dogma of the day, in this scenario, it's really something we want to try and manage without taking off the leg. This is probably the largest meta-analysis looking at mortality outcomes in patients with amputations in diabetes, or in general. I think it was peripheral arterial disease. But what's striking is you look across the papers that the 5-year mortality at best is in the 50% and is as high as 80%. So you can really see why people would make the contrast to malignant disease in terms of long-term outcomes. Now, one could argue, well, peripheral arterial disease or diabetes, these are diseases that confer an increased mortality in their own right, and that's taken into account. If you look on the left, type 2 diabetes with and without low extremity amputation, and again, you can see the Kaplan-Meier plots and how they diverge. The mortality is always higher with the low extremity amputation. The paper on the right from Clinical Kidney Journal, again, looking at the top line, that's patients with no amputation, no diabetes, and CKD. And the next line is patients who have diabetes without an amputation. So these are all CKD patients. The moment you take off, you do a major amputation, whether it's CKD or not, whether it's diabetic or not, the lines tend to coalesce and the mortality drops off dramatically. Now, not all amputations are created equal, and it's important to be aware of that. We talk about major amputations being above knee and below knee. And minor amputations being those that tend to involve the forefoot or a ray amputation and a toe amputation. And the latter tend to have much less effect on long-term morbidity and mortality. So those become options. Again, just looking at long-term mortality in patients with minor versus major amputations. And again, you can even stratify it further in the graph on the right based on a forefoot amputation versus a below knee versus an above knee. Although a lot of the data suggests that above versus below knee amputations both tend to have fairly dismal long-term prognoses. So how common? How common is it for someone to have a diabetic foot, to have an amputation as a result? Well, worldwide, one amputation second to diabetes every 30 seconds, estimated to be around 1 million annually. The annual incidence of a diabetic foot ulcer in the UK is around 2%, and in the US, with the burgeoning obesity epidemic is a little higher, 5 to 6%. Now, local data is scant. There's no centralized database in South Africa, so we don't really know. There's only been 3 studies in the last 60 years looking at outcomes in diabetic foot complications in South Africa. Looking at one of the papers, the most recent of the bunch, specifically was set in Gauteng, and they tried to be holistic, at least in a cluster of Gauteng, to try and establish what's the prevalence of amputations, and it comes down to around 59 to 100,000 per year. And just for comparison, HIV-related deaths are around 110 per 100,000 per year. That was in 2017 through 2019. But what's a little bit scary is that the majority of these first amputations are major amputations, which implies that our patients tend to present a bit later than we would like. And you can't do limb-sparing surgery as an attempt to avoid this outcome. Now, this is a quote from the previous IDSA guidelines for diabetic foot infection, and I really liked it because it captures the problem. The main problem is currently less our lack of full understanding of the problem as much as our failure to apply what we know actually works. And that's sort of what I'd like to touch on today and address. So let's start with the basic pathogenesis of diabetic foot ulceration and ultimately infection. So it's really a multifaceted process. So there's the peripheral sensory component on the left. So I'm just going to turn on a laser pointer here. The peripheral sensory neuropathy with decreased pain and pressure sensation, impaired proprioception. Then there's the motor neuropathy, which I think people discount, but the foot deformities that occur are often the precursor for the diabetic ulceration. The presence of an autonomic neuropathy results in decreased sweating, drier skin. These patients are more prone to develop an ulcer and less prone to heal. And then the concurrent epidemic or macrovascular component of peripheral arterial disease with resultant tissue loss and impaired wound healing. All of this results in a callus, and the callus ends up resulting in foot ulcer development. Now, just to touch on the motor neuropathy, it's important to know that the 2 versions of this, you can get a high arched foot, you can get a flat foot, and both of these affect the biomechanics of the foot and put disproportionate amounts of pressure on specific points. And those are the points where we'll classically see ulceration over the tops of the toe, or sort of on the foot pads, or bunions on the sides of the feet. And those are the classical initial sites of a diabetic foot ulcer. Once you have the callus tends to bleed underneath, and that eventually causes necrosis of the overlying callus, which will fall off and leave you with the ulcer. And the depth of the ulcer can vary, but what's important on the foot is that you don't have a far distance between the ulcer and the bone. And osteomyelitis is a common sequel of these events. Then you've got to add on top of that diabetics have impaired wound healing. On the left, many of the components that contribute towards normal wound healing. On the right, how in a diabetic, things like macrophage activation, things like granulation being appropriate, things like angiogenesis, these are all impaired in some way, shape, or form, resulting in impaired wound healing from the get-go. You couple that with then you have a chronic open wound, and this is a theoretical framework where you have contamination, ultimately colonization, and there's this theorized critical colonization point. They've tried to put a number to it at around 10 to the 5 colony-forming units per gram of tissue. And at that point is thought to be the transition point between local and or invasive infection. Again, oversimplification, but it's an important understanding of how we progress. And then this discussion wouldn't be complete without mentioning a biofilm. Biofilms in diabetic foot infections are a fundamental component of the pathogenesis. And obviously, we know that this involves a couple of components. The cells adhere to the substrate. They form these sort of microcolonies. They, via quorum sensing, decide it's time to switch off from being planktonic organisms, and they become embedded. They secrete all the peptidoglycans that essentially protect them and seclude them. And you can see here how secluding themselves prevents the host immune system from getting to them. It prevents all the cytotoxins, prevents the antibiotics from getting there, and essentially forms a protective coat, preventing clearance of these organisms. Intermittently, they'll shed, and some of them will revert back to planktonic organisms, and these have the potential to then become invasive. Now, how does one suspect that there's a biofilm involved in the infection? Well, again, excuse the images. I hope no one's had a recent lunch. But there's a number of things that'll happen. So you'll find failed antibiotic treatment or recurrence after seeming clearance. You'll find that low-grade chronic inflammation occurs. You'll have multiple infections in the same ulcer that seem to get better with antibiotic therapy, but recur once it's stopped. You have sort of soft signs of infection, friable granulation, undermining of the wound, or you might have culture negative results, despite the fact that it looks like there is, in fact, an infective process. Okay, an ID talk would be complete with discussing the microbiology of these infections. And this is fundamental to understand our role in terms of which antimicrobials we can use. So again, this is from a recent systematic review published in BMC ID. And you can see that the overwhelming player in these infections is going to be Staph aureus. Okay, we know that Staph is the major player. But the gram-negative shouldn't be discounted. E. coli, Pseudomonas, Proteus, and Klebsiella seem to be the most common. Okay, note that this is when we look at aerobic cultures. The moment we try add anaerobic cultures, a couple of other players come to the fore: Bacteroides, Streptococcus. So it's important to know these infections are often polymicrobial and may or may not involve anaerobic organisms in terms of our choice of antibiotics down the line. Then there's the fact that there's discrepancy between high and low middle income countries, often based on where you are relative to the equator or tropics or warmer climates. There are some subtle differences. The key ones being that the gram-negatives, especially Pseudomonas, tend to be more common in low or middle income countries. So this is worldwide data. What about local data? So this is from Sub-Saharan Africa. It's a meta-analysis looking at locals, a couple of studies from Sub-Saharan Africa. And the specific one I wanted to focus on is Pseudomonas, because the prevalence of Pseudomonas in Sub-Saharan Africa climbs to around 20%. So it's not insignificant. Unfortunately, none of this is representative of South Africa. Most of these countries are certainly further north than we are. So whether this can be extrapolated to our local data would be somewhat of a stretch, and it's unclear. Then there's the fact that when we look at culture-based methodology, we're actually looking at the tip of the iceberg. The moment you expand things to culturomics, to things like MALDI-TOF or molecular methods, RNA sequencing or metagenomics, it expands dramatically. And you can see, I mean, these are in each of these are the species that are identified. There's the one that seem to carry through, but you can see that it expands dramatically. Again, another paper looking at this, but including the role of fungal organisms in these infections. Now, I use the word infection lightly. The question is, what is the implication of all these bugs? Do I need to change management? Do we need to actually target them? And the answer is probably not, but they may certainly play a role in the pathogenesis of the ulcer itself and or the colonization and the overall microbiological milieu that results in the progression of or non-healing. But it's still unclear what we do with all these organisms. So let's cut to the meat of it. How does one diagnose a diabetic foot infection? So I just want to touch on three components. The first is some of the preventative measures that we should be doing in clinical practice. How do I formally make a diagnosis, and when should I suspect osteomyelitis? And lastly, what are the supportive investigations that I can do to support my diagnosis? So obviously it goes without saying that prevention is better than cure. And that needs to be something that we take into account. But the problem is this: how do I screen, diagnose, and educate my patient on diabetic foot ulcers and diabetic foot infections when I'm in a busy clinic, seeing lots of patients? There's throughput. And obviously we need some sort of efficient mechanism to do this within the context of such a consultation. So the motto is simple: efficiency, efficiency, efficiency. Probably more efficient just to say it once. So I came across this paper, which I thought was quite nice: how to do a 3-minute diabetic foot exam. And what's nice is there's a fair amount of evidence that backs this up. Level of evidence was class A, and studies showed reduced amputations, reduced admissions, and better economic outcomes. So it works. So what are the components? Firstly, what to ask. Spend 1 minute. Does the patient have a history of previous ulceration or amputation, previous vasculopathy, any prior foot wound that took a long time to heal? Are they a smoker? And if so, are they considering cessation? What are they doing for their diabetes? And then, do they have any symptoms or precursor symptoms of a diabetic neuropathy or vasculopathy? And lastly, are they seeing a podiatrist? Then what do I look for? Well, you take a look and see, do they have ingrown or elongated nails, fungal infection, which would suggest poor diabetic control? Do they have active calluses or corns, which can be an early point for intervention to prevent progression? Do they have any open wounds, fissures, any interdigital maceration, athlete's foot, things like that? Then the neurological exam, a quick screen for the presence of a sensory neuropathy, which is the earliest prognosticator or portender of the development of a diabetic foot. And lastly, does the patient, in terms of the musculoskeletal exam, are there any obvious diabetic related motor neuropathy deformities? And quickly, is there a problem, an obvious problem with the vascular exam, reduced hair growth, absent pulses, temperature difference? Then lastly, what to teach, again, talk the patient through how they must visually examine the foot, keep them dry, foot care, ensure they're wearing correct shoes, not too tight, not too loose, orthotics, etc. And then obviously recommend. And this can be done in 3 minutes and seems to make a dent. Okay. How does one screen for sensory neuropathy? Again, in clinical practice, well, this I think everyone's familiar with. We all learned this back in the day. The Weinstein monofilament test, and again, using a 10-gram monofilament, certain pressure points on the foot predicts the presence of a diabetic neuropathy. And this is old. I mean, this was described in the 60s by Sims and Weinstein, amongst others, as an early screening tool for the diagnosis of a sensory neuropathy, diabetic or other. Problem is, I don't know about you, but I very rarely come across monofilaments in our clinics. Even before my exams, I'm struggling to find one at a medical supply shop. So is there an alternative? And yes, there is. This is what I tend to use, the Ipswich touch test. And it's quick. Essentially, what you do is you ask the patient to close their eyes, you tell them you're going to touch their toes, and you touch them on the tip of their toe, telling them to tell you left or right. And you go in a very specific order. You can see the order there, 1, 2, 3, 4, 5, and 6. Less than 2 seconds that you touch. And if they don't reply, you don't wait for them to reply, prompt them. It's a quick test. And if they can't feel 2 or more toes, they have reduced sensation and at risk of a diabetic ulcer. And what's nice is that this correlates quite nicely with a monofilament test. So even in the absence of having the equipment, you can do a fairly accurate screen with a fairly good positive predictive value, around 89%, just within 12 seconds touching 6 of their toes. Okay, then going clinically, well, again, once you have not just a neuropathy, but an active ulcer, that's obviously quite clear. But it's important to pay attention to the type of ulcer that one could have. So, I mean, you can have an early neuropathic ulcer that's not clearly infected. You can have overlapping features of a neuropathic ulcer and or ischemia, or you can have a purely ischemic foot. Now, it's not always so simple. I mean, there are things like Charcot's neuropathy, which can really mimic quite a nasty looking cellulitis or even osteomyelitis. And that's something to be cognizant of when you see a patient with diabetes who comes with a hot, swollen, red foot. Some of the useful differentiators, and we'll talk about some of the biomarkers and other components to this, but some of the useful differentiators include things like the location. It's typically in the midfoot. It typically involves the bones and the joints underlying this. There's obviously not always an ulcer, although that's not something that can be excluded. And again, there are subtleties on an MRI that can be used to differentiate them. But essentially, it's more commonly going to be a clinical diagnosis. But the important thing is not to forget any of these, because these are patients who don't have overt infections. So maybe we would be less interested. But these are all things in which we can intervene. The presence of edema impairs wound healing, and simple diuresis or compression stockings can assist with that and improve their wound healing down the line. The presence of this accentuation of the arch, hammer toes, with the abnormal biomechanics that it confers an increased risk of pressure-related foot ulcers, and similarly the presence of a flat foot. And then the last but not least is the presence of an early corn or callus, which may seem insignificant, but is the precursor for an overt ulcer, which will almost invariably get infected. And this can easily be dealt with a podiatrist and addressing the underlying biomechanics that led to it. How often should we screen our patients? Again, depends on if they've previously had an overt diabetic foot, depends on the presence or absence of features of the diabetic neuropathy. And it ranges from anywhere from every 3rd month to once a year. Finally, how do we get to the diagnosis and classification? Don't worry, I've got some images. So this is the most recent classification recommended by the IDSA and the International Working Group for Diabetic Foot. So obviously the starting point is that there's no infection. This is a pure neuropathic ulcer without any erythema around it. It's not obviously infected. What about once it becomes infected? So here it's where you have local swelling, induration, and an area of erythema, but it's less than 2 centimeters around the wound. It may be tender, it may be warm, and there may or may not be purulent discharge. Obviously, exclude any other cause. That will be classified as mild. Moderate looks like that. So this is an infection with no systemic manifestations, but it involves either erythema that extends beyond 2 centimeters from the wound, or tissue deeper than skin and subcutaneous tissues like tendon, muscle, or joint that become exposed within the undermined ulcer. The presence or absence of osteomyelitis also classifies you as at least a moderate infection, and one should add the qualifier O. And then severe, this is essentially where you have systemic features of an inflammatory response, so any of your typical SIRS criteria or significant leukocytosis. I'll draw you to an alternative. Well, it's not so much an alternative as much as an expansion from the Society for Vascular Surgery, and there's some proponents for this classification called the Wi-Fi classification. So on the right, it's essentially exactly the same as the classification for an infection. But what's important about this classification, it works almost like your TNM, where you'll have a 000 or a 010, but the ischemic component is an important component to assess as part of your overall assessment of a diabetic foot. Because failure to actually establish that the patient has peripheral vascular disease obviously will portend failure of any form of medical or surgical therapy. And it offers us something with which we can intervene. A vascular surgeon can consider revascularization, and that will likely benefit the outcome and has been shown to prevent progression and improve wound healing down the line. The recommendation is not to use just the dorsalis pedis or obvious clinical markers. One should use the ankle brachial index, so measure blood pressures in the ankle and the brachial artery, and the index can be helpful, or newer modalities like a toe pressure cuff, small cuff that fits over the toe, or even something called transcutaneous oximetry, which correlate quite nicely with the presence or absence of ischemia. So these are things to add on as adjuncts to stage our patients and to give us an additional area that we can intervene to improve their long-term prognosis. What about the use of biomarkers? And unfortunately, this is rife with ups and downs. It's not always so clear. The IDSA guidelines make this vague recommendation that one should assess inflammatory biomarkers such as a CRP, SR, and a PCT in a person with diabetes and a possibly infected foot ulcer when the clinical exam is diagnostically equivocal or uninterpretable. But they don't give a clear cutoff. So there's a meta-analysis that they refer to, and I went down to the meta-analysis, and actually there's vastly different cutoff values. That's one of the problems. And interestingly, the main utility is where your clinical exam is equivocal to decide is there no infection versus a mild infection. And the other place they're useful is in establishing the likelihood of a patient having underlying osteomyelitis. And interestingly, an oldie but a goodie, ESR, even though we don't like it in general, it actually performs best for both. And it's probably because of the somewhat chronic or subacute nature of these infections. So a cutoff of 39 for the diagnosis of at least mild infection, again, has a diagnostic odds ratio of 27, and those are the 95% confidence intervals. And for osteomyelitis, a cutoff of around 70 also performs fairly well in scenarios where things are somewhat equivocal or clinical and or imaging exams are unclear. CRP, unfortunately, doesn't perform particularly well. It's terrible at excluding infection. Obviously, if it's very high and the cutoff of 200 was given, it has a reasonable specificity. They're also useful specifically to differentiate, as I discussed earlier, with a Charcot's arthropathy, where the median ESR is only around 21, the CRP is pretty low. And so, again, if you're concerned that this patient may have forefoot or midfoot osteomyelitis versus a Charcot's foot, an ESR that's low, a CRP that's low, may well be useful in those patients. The next thing is diagnostic samples. When and what? What should we actually take? So the first thing is, should we use them to make the diagnosis of infection in the first place? And they actually suggest that to make the diagnosis of the presence of an infection, not to use quantitative microbial analysis. So there's studies looking at specifically taking a biopsy of tissue and quantifying the number of organisms, as I mentioned above, that critical concentration of 10 to the 5 colony forming units. But the problem is there's varied definitions. All the studies are quite prone to bias. This is a very resource-intensive methodology, and the concern is it'll likely actually lead to antibiotic overuse because these wounds are almost invariably chronically colonized. Once you, however, do have an infection that you've established based on clinical and plus minus biomarker evidence, it's beneficial to obtain tissue to guide therapy. And so they suggest collecting or sampling sample for culture to determine the causative organisms, preferably by aseptically collecting the tissue specimen via curettage or biopsy from the wound. So you're supposed to ideally do this in theatre, or at least clean the wound thoroughly and take a deep sample to actually send for MCNS or culture. They suggest caution with repeat samples in these patients, especially if they spend time in the hospital. You're much more likely to overdiagnose contaminating multi-drug resistant organisms, which will wreak havoc on long-term antibiotic regimens. And then obviously this goes without saying, but I'll say it anyway, that liaison between the clinicians and the surgeons in terms of the nature of the specimen that was taken is key to facilitate the way in which we actually interpret it. And then lastly, it may be reasonable to use empiric therapy in non-severe diabetic foot infections with no recent antibiotics or any other risk factors for MDRO. But there's a caveat for that. Again, this is a paper published last year. It's a retrospective paper, but it actually showed that going empiric in mild infections in these patients actually increases your hospitalization rate. And again, it's an older study. The data was from 2019, so it's sort of pre the Oviva time. So patients were perhaps spending a bit longer in hospital than they needed to. It's subject to the usual bias and confounders of a retrospective study, but still something to bear in mind that potentially treating empirically without sampling may increase the hospitalization rate and duration. What about wound and pus swabs? Well, I think this goes without saying, but don't use pus swabs, okay? But at least 2 systematic reviews of retrospective studies, 2 prospective trials. They show a higher sensitivity and specificity of tissue versus superficial swabs, and most importantly, a very poor correlation of the organisms one would identify, which again can really lead you down a rabbit hole. And a soft tissue biopsy, it's a small piece of tissue in a fairly insensate wound that already probably needs debridement. The risk of just doing a tissue biopsy far outweighs, I mean, the risk of biopsy is far outweighed by the benefit of having some microbiology to guide therapy. What about using molecular methods? As we discussed above, it yields a plethora of organisms, but the recommendation from ITSA is to use conventional rather than molecular microbiology for anything, whether it's soft tissue or bone samples in a patient with diabetic foot. Now, again, the first thing is that for the most part, they'll agree with the significant pathogens that you'll identify using conventional methods, except anaerobes, and perhaps if the patient's already on antibiotics from a bone biopsy. You tend to identify a lot more organisms, but again, the significance and benefit of these organisms, of treating them, and the given cost that will incur, and the cost of the tests themselves, the IDSA advise against it. Again, some of the issues, we don't know if they're alive or dead. We don't know which of them actually contribute to the infection and may require targeted therapy. And again, a lot of the studies are prone to bias. We have a high cost of molecular methods, which in a low-income country such as ours may be difficult. Where they may have utility is obviously to further delineate the pathogenesis of a diabetic foot ulcer or the infection. What about establishing bone involvement? And this can be trickier than one would imagine. So to make the diagnosis of osteomyelitis, so sometimes it's clinically obvious. The patient can have visible bone, goes without saying, very wide and deep wounds, the presence of a sausage toe, which again implies that there's significant periosteal inflammation. But the probe to bone test, and I'll show some of the data around that and how it's done, is a very useful tool. We'll go into it a little bit. As discussed above, biomarkers may have a role. Imaging, if unclear, and specifically X-rays, there's a whole host of features that can be suggestive of underlying osteomyelitis. The problem is that they are not particularly sensitive. The absence of these features is in fact pretty common. And what's important is that if you are going to use X-rays, often spacing them several weeks apart is going to give you more data than a single X-ray done in time. Because progression is often more telling than what you see initially on an X-ray. MRI or nuclear imaging are certainly indicated if it's unclear. And MRI, again, is very useful in this regard, but the problem is obviously access. Bone biopsies are indicated to confirm the diagnosis if it's still unclear based on the above, and if you have confirmed the diagnosis to guide antibiotics. And they recommend taking a bone biopsy even over soft tissue samples if you have a suspicion or confirmation of diabetic foot osteomyelitis. The method does affect the results. So if you take it through the wound versus through a clean part of the foot, so transcutaneously versus through the wound, they only agree 42% of the time. Now, what that means is difficult to interpret. If you're finding something in the wound and finding something if you're going aseptically through the skin. But the recommendation is to try avoid going through the wound if you can, unless it's in the setting of intraoperative where you've debrided the wound appropriately. There may be some benefit here of a post-antibiotic free interval up to 2 weeks, which improves the yield of false negative bone biopsies. And lastly, it's important to correlate histology and culture. And in my osteomyelitis talk, I touched on this. I remember that, again, because of the risk of contaminating the sample in these fairly colonized and contaminated wounds, one would want to confirm that on histology, there are histological features of osteomyelitis and visible organisms as well. How's a bone biopsy done? Again, this is if you're going to do percutaneous, assuming you've obviously anesthetized the foot. It's sort of like a core biopsy that we use in a bone marrow needle, much smaller needle, and one goes percutaneously within the core of bone and removes that and ideally divides it and sends it for both microbiology and histopathology. Okay. Looking at the probe to bone, this is how it's done, physically probe to bone. Again, it's quick, it's a little bit dirty, but it's actually quite easy, and it essentially relies on the idea that if you're able to touch the bone with a blunt instrument like a sterile metal probe, or even the back of a sterile pus swab, the ones that sort of come within an enclosed container, and using the back, and if you can feel the gritty sensation of the bone underneath as you touch, that's suggestive of the presence of osteomyelitis. And again, performs pretty well with the diagnostic odds ratio. This is an old study. No, actually, this is the newest study. The diagnostic odds ratio of around 32. So really, it can be very helpful if present. And how does it compare with all the other imaging modalities? Well, if you look at MRI, pooled diagnostic odds ratio, again, this is a slightly older study, but of around 24, with fairly good sensitivity, slightly poorer specificity. But you can see that probe to bone, in fact, performs as well, if not better, than various forms of imaging. So if it's present, if you are able to probe to bone, very useful diagnostic modality to confirm the presence of osteomyelitis in the patient with the diabetic foot. All right, and lastly, let's move on to how you physically manage these patients. What do we do? What are the primary components of care that one needs to apply? So the first thing is the importance of a multidisciplinary team. And this sounds cliche, but it actually has a fair amount of evidence behind it. Exposure to an MDT is in fact predictive, it's protective of a lower extremity amputation, up to a 56% reduction in amputation rates across varying studies. And again, it's a big team, involves a lot of people, and each one has their role to play. I will say that I think obviously controlling the sugar, addressing the right antibiotics between the ID and microbiologist, and the surgical components are fundamental. But what comes next is preventing progression of the ulcer by providing appropriate orthotics and rehabilitating the patient, appropriate wound care. So there's really a lot of players here, and they all should be involved, and we need to get better at doing this. And lastly, a few useful components. This is a graphic from one of the other papers that we often forget about. And specifically, I'll go towards, for example, assessing and treating these patients' mood disorders. These patients are often prolonged, sort of prone to prolonged immobility that can wreak havoc on their moods. You need to optimize the sugars. You need to offload the wound and address the underlying biomechanics. You need to provide long-term wound care because these take a long time to heal. You need to make sure we're addressing the vascular component. And then there's a number of barriers to care that I'm 100% certain are applicable in our setting. Things like difficulty accessing healthcare, transportation, the socioeconomic components. And it's important not to forget those as fundamental parts of the management package. Who should I admit to hospital? Again, some of this is fairly obvious. Patients who look ill, patients who have large and complex wounds, patients who have significant cellulitis or localized crepitus or lymphangitis and overt cellulitis. So again, I think this is sort of goes without saying. The patients you think need admission probably do, but the corollary is that those that don't need admission probably don't need admissions. Certainly your milder infections, you can probably get away with ambulatory care in the majority of them, assuming you have the right stuff available to provide them with the ambulatory care. Surgery, well, obviously I'm not a surgeon, so again, I'm going to touch on this based on how the guidelines describe it. So the first thing is that a mild infection not extending beyond the fascia and without osteomyelitis, extensive collections on necrotic tissue can be managed without surgery. So there's a subset of these patients that doesn't need a surgeon, or certainly doesn't need overt surgical intervention. They might need help in terms of biopsying things. A trial of non-surgical management in isolated forefoot osteomyelitis. So even if they have osteomyelitis, there is the consideration if it's localized to the forefoot without any of these other collections, necrosis, exposed bone, or severe peripheral arterial disease, is also reasonable, and one can get away with antibiotics alone. In some scenarios, surgery may, however, make sense, even if you meet the above criteria. For example, you have a distal phalanx of a hamartose, so it's isolated forefoot osteomyelitis, and there's no other clear indication to surgery. But again, the fact that you have the hamartose will likely predict that you're going to develop another ulcer, and potentially removing that improves the foot biomechanics. So again, an isolated toectomy may well be beneficial, even if there's no clear surgical indication from an infection perspective. Moderate to severe infections require urgent surgical consultation. We should be calling our surgical colleagues early, and features suggestive of peripheral arterial disease require early vascular consultation. Again, that's where that Wi-Fi score comes in, preferably using non-invasive testing rather than just the clinical exam in these patients. So easy things like an ankle brachial index may be useful. The surgical treatment should be done stepwise, obviously starts as distal as possible with the goal of achieving functional limb preservation as much as possible. If you do require surgery, however, in severe infections, especially, surgery should be performed early, ideally within 24 hours, and you have a lower rate of major amputation if you can do a sort of forefoot amputation, toectomy or ray amputation within 72 hours, and frequently. And again, the evidence suggests that at least weekly debridement in these complicated wounds associated with best outcomes. If you have osteomyelitis and it is possible to resect it, it's obviously useful, and that can be useful on two fronts. Number one, source control. Number two, establishing if your retained margin is in fact negative, in which case you've got all the infected tissue, and that has implications for antibiotic choice and duration. It's difficult to clearly compare the outcomes in a systematic review with or without surgery, but there's at least one attempt which showed, again, the gist of it: in non-operative management, a mean success rate of 68%, and operative management, a mean success rate of 85%. So the usual issues with it being a retrospective study, but the take home is that non-operative management can be successful in the right patient subset. All right, moving on to our area. So drugs, again, this is a table straight out of the guideline, but I'll discuss some of the rationales for what they do. So firstly, in a mild infection, they say that GPCs covering your staph may be strep. So something like cloxacillin or Keflex is probably adequate, assuming the patient has a very mild infection. If they've recently had antibiotics, one should probably broaden that a little bit. And beta-lactamase inhibitors like coamoxiclav, ampi-sulbactam in the States, if they have it, are good choices, especially given the polymicrobial nature of these infections. The MRSA discussion I'll skip because it's less relevant to us. Moderate or severe infections. So there again, one should probably start at that second tier with something like coamoxiclav or second to third generation cephalosporins. If one's had recent antibiotics, one can consider sort of broadening cover with piperacillin, tazobactam, or even considering carbapenems, although I'll discuss one caveat to that. They suggest if you're in a macerated or warm climate, so again, based on that Pseudomonas data, although none of it, as I've said, is local data. So again, in sub-Saharan Africa, based on the ITSA guidelines, they would recommend in moderate to severe infections upfront covering Pseudomonas with things like piperacillin, tazobactam. And then obviously for ischemic limb necrosis or gas-forming organisms, one would stick to the standard recommendations and consider things like clindamycin as well. Again, in summary, the treatment is stratified based on severity, the risk of resistance, and geography. But again, this is a guideline only. There's multiple other considered factors: availability, local protocols, and antibiograms. So there's a lot of work we can do to try and tailor this to where we work. And one also has to take into account cost, patient-based factors, and the risk of collateral damage. So it's not clear here in moderate to severe infections whether one should or should not cover Pseudomonas. and there's no local data to really inform that. As mentioned, early tissue and bone samples can guide antibiotics and certainly facilitate step down to oral antibiotics, and we'll touch on that next. No antibiotic class has clearly been found to be superior to another in several meta-analyses. There's two single studies that do go against the grain. There was one that looked at tigecycline versus ertapenem, and tigecycline actually failed to meet non-inferiority. There were a whole bunch of potential explanations for this, but again, it's just bears witness to the fact that we need to be cautious with tigecycline perhaps in these patients, even though it seems like an attractive option in terms of its soft tissue penetrance and its spectrum of activity. And then there was one other study from China comparing ertapenem versus piperacillin tazobactam, which showed lower cure rates for ertapenem overall, and in the subgroup of severe diabetic foot infection, a lower rate of resolution that met statistical significance, although it was a subgroup analysis. So again, just some caveats to bear in mind when choosing the regimen one's going to choose. What about oral antibiotics in diabetic foot infections and diabetic foot osteomyelitis? So oral therapy in skin and soft tissue, that goes without saying, and we should obviously be able to extrapolate that to a diabetic foot infection. But what about osteomyelitis? So again, we know this has been discussed. There's at least 8 randomized trials showing oral step-down therapy in chronic osteomyelitis is non-inferior, although some are quite a lot older. And obviously the Ovivus trial, which most of us are familiar with, is the largest and most robust. But the question is, can one extrapolate that to diabetic foot? Or diabetic foot infections associated with osteomyelitis. So if one goes to the Aviva trial, 20% of the patient population, quite a big chunk, had diabetes, but how many of those were specifically diabetic foot osteomyelitis is not stated, even in the supplementary appendix, and one would have to go back to the original data. The organism is often not clearly defined in a diabetic foot osteomyelitis. That we know. Sampling is not always accessible. Sometimes we do have to rely on empiricism. In Aviva, there were 20% of patients that required empiric therapy. There was no available microbiology. But in the subgroup analysis, this was one of the groups where there was a trend towards worse outcomes. So just bear that in mind. And lastly, these diabetic foot infections where a drug like coamoxiclav, or sort of thinking broad penicillins with good anaerobic cover, good gram-negative cover, seem attractive. Just a reminder that oral beta-lactams trended towards poor outcomes as well. And likely that's a result of the pharmacokinetics, dosing, and adherence with those drugs. And so these are reasons for caution if you're going to use these drugs based on available microbiology or empirically. So the ITSA guidelines, they encourage oral antibiotics in milder infections and certainly encourage step down in more severe infections after a period of intravenous therapy. But obviously I would just caution to use these with the above caveats in mind in terms of one's choice of antimicrobials. Lastly, on the drugs, the choice of drugs, rifampicin. I'm sure some of you are rolling your eyes and saying, not this again. So again, we know it's established because of its effect on biofilms in osteoarticular infections with retained prostheses. It's not as clearly established in other cases of osteomyelitis. Again, we'll find proponents for and against based on the small trials, animal trials, some older data. The osteomyelitis guidelines offer it as a step-down option in combination therapy, but they don't specifically recommend it. That's for specifically native vertebral osteomyelitis in adults. So in diabetic foot infections with osteomyelitis, again, as I mentioned, Staph aureus is the most frequently isolated organism, and biofilm is considered a significant component of the pathogenesis. So really, it seems an attractive option and theoretically would have a significant role. There's at least 2 retrospective studies that show benefit, much higher cure rates, lower risk of amputation, and mortality. But again, retrospective data, there's one ongoing large randomized controlled trial called the VA Intrepid Style in America, which hopefully will answer this question. I think it's still enrolling until 2024. So exciting times ahead, and hopefully we'll have some more data on this. How long? Again, this is something that one obviously needs to use one's common sense and individualize. But for osteomyelitis that's managed non-operatively in keeping with standard recommendation, 6 weeks. What happens if you've debrided, but it's not a curative debridement or amputation? So especially if you've got margins that suggest that there is persistent infection at the margin of amputation. So again, 3 to 6 weeks is the recommendation. There's at least one small trial showing that 3 weeks was non-inferior to 6 weeks. Soft tissue infections, again here 10 to 21 days, the recommendation, again based on at least one small randomized trial showing that there's non-inferiority. And then if you've done a curative amputation in a patient with clean margins, the recommendation is you may not need any, but probably a maximum of 2 days. And all of this, again, those are the taken from Brad Spellberg's website. These are the references that inform these durations of therapy. And as he would say, shorter really is better. This is, again, it's astounding that we don't have a clear explanation for this, but actually it's not clear how one defines cure in diabetic foot osteomyelitis. So they suggest using the outcome at a minimum follow-up of 6 months after the end of antibiotic therapy to diagnose remission, not cure, of diabetes-related osteomyelitis of the foot. Things you can use to suggest that you're winning is resolution of the overlying signs of infection if the wound's starting to close. Plain films that initially had progression and now stop progressing, again, not routinely recommended, but if one's stuck or it's unclear. There is potentially a role for things like white leukocyte-labeled scans in nuclear medicine. Again, there's not enough data. And then inflammatory markers may be useful if they were initially raised, but as I mentioned, they're not always raised in these patients, especially milder disease. And the reality is only around 50% of ulcers are fully healed at 1 year with absolute skin integrity. So it's important, the key thing is to not keep throwing antibiotics at an ulcer that is no longer infected. So it's no longer an infection, but just a diabetic foot ulcer. Obviously, one needs to address the cause of the ulcer, address the wound care, and address the things that led to the patient developing the ulcer in the first place. And those need to be the priority at that point. What happens if the patient doesn't respond? Again, this is from not the last iteration, but the one before that, from 2005 of the IDSA. So again, some of this is logical, but I'm going to go through it because these patients sometimes are difficult. So the first thing is, do you have tissue? Send for culture, and if not, that's something you can do to change course. Or is your antibiotic regimen covering what was isolated on the tissue? Again, like we said, we're not always sure exactly what you need to cover from what we do isolate, but perhaps if the patient's not getting better, it gives you targets to expand. Was surgical debridement, drainage, and resection adequate? And obviously involve the surgeons. Has the patient's glycemia and wound care been optimized? And their biomechanics. And lastly, the vascular component, never to forget. If the patient does not perfuse the foot well enough, the ulcer well enough, it won't heal, the antibiotics won't get there adequately. And so that's sort of a stepwise progression. I'm going to literally 2 slides and then we're done. And adjuncts, a word or two. So again, there's a whole bunch of things that have been trialed in terms of adjunctive treatment of the infection of diabetic foot infections and ulcers, from colony-stimulating factors to all sorts of weird and wonderful dressings with silver impregnation, honey-based enzymatic hyperbaric therapy has been trialed, local oxygen therapy with interesting devices that essentially create a high 100% oxygen atmosphere around the foot itself, and then some of the newer stuff like bacteriophages, and some of the older stuff like negative pressure wound care. So the IDSA guidelines essentially do this. Before you ask, the answer is no. And they just say that essentially there's limited to no evidence to suggest clear benefit of one thing over the next. GCSF as an example, there were studies that showed it might increase the time to wound healing in some cases, but again, it's very expensive and there are small studies. Things like silver impregnated dressings or the various enzymatic or honey-based dressings, there's nothing that clearly shows one over the next is clearly better. Hyperbaric therapy, putting these patients in a hyperbaric chamber, again, resource intensive and hasn't clearly shown benefit. Then what about local oxygen therapy? Looks quite promising, at least in sort of pilot trials, but there's just not enough data. And the same would apply for bacteriophage therapy, and certainly something we'll think about, although in these polymicrobial infections, one does have to have some hesitance considering bacteriophages, given that they are specific for certain organisms. The last thing I'm just going to touch on is negative pressure or VAC, because they sort of quite clearly say no clear evidence. But a lot of the surgeons are quite strong proponents, and I think this is quite established in wound care in general. And these are at least from 2 studies, one from Diabetes Care and one from the Lancet, using negative pressure wound care specifically in diabetic foot ulcers and infections, showing that your time to healing and time to granulation seems to be shorter. So there is probably some benefit. One caveat, obviously, is access to the devices. You can get small portable devices that you can take home if the wound's small enough, but the sponge within has to be changed every week. Otherwise, you risk significant infection. So again, I think that's the one that I think is quite established already, at least in actual practice, and the one that I wouldn't discount absolutely. There's a ton of ongoing questions, things like, are we there yet? How do we even define cure, as I touched on? Which biomarker? If so, how and when? Could even shorter be better? I'm sure someone's going to eventually do trials of even shorter durations of antibiotics. When and what should I image? What's the role? We need to better define that. What's the role of new antibiotics? All our new beta-lactam, beta-lactamase inhibitors, but especially the new lipoglycopeptides, telvancan, and a lot of those drugs are quite attractive. Oral drugs with good tissue penetrance, good MRSA and gram-positive cover. So again, attractive, but again, not a lot of data yet, something that will evolve. What's the role of molecular biology, if any? So in conclusion, so diabetes prevalence is increasing at an alarming rate worldwide. So we can concurrently expect the prevalence of diabetic foot infections to increase in turn unless we get better at prevention of diabetic foot ulcers. These infections devastate the patient's mobility, independence, quality of life, and post-amputation mortality dramatically reduces lifespan, again, as bad as malignancy. The diagnosis and classification isn't always easy, but certainly guidance has improved, and using recognized classifications and ancillary diagnostics, we can usually get there, and we should. Multidisciplinary teams are paramount and improve outcomes and really should be something we strive towards. Surgery will usually, but importantly not always, be required. Ideally, earlier is better, but major amputation is a catastrophic event to be avoided if at all possible. And lastly, antibiotics are the cornerstones of treatment, and shorter durations of more oral therapy is promising, but consider the caveats we've discussed. And in many or most areas, there are still more questions than answers, and research is needed to clarify in detail the roles of certain things in many areas. There's a lot we can do in both prevention and treatment, with evidence backing what does work, but we just need to apply it.
Cool, thank you so much. Really nice overview of a pretty complicated topic at the best of times. There's some questions are coming in for it. I guess just the one comment from me before is that you showed really nicely on the sort of pooled meta-analysis about probe to bone and MRI and various other modalities. And if you can get an MRI relatively quickly, it's useful after probe to bone if you can. So the reason being that the probe to bone is pretty good specificity, in fact, very good specificity, but not that great sensitivity. So you can try that. And if it's positive, no need for an MRI. Then if that's negative and you have still concern, you can do an MRI, which is sensitive, but too sensitive, it overcalls some of it. So it's helpful to do next, but it's just nice to pair them, if you know what I mean, because probe to bone is so easy. I mean, costs absolutely nothing and it's usually possible. So it's a nice way of saving a whole bunch of MRIs if you're in private, which otherwise overcalls it. And like I said, in fact, MRIs are also terrible at follow-up because they end up lighting up for months after successful treatment.
Yeah.
Very expensive stuff. Cool. So one question was, does the presence of certain bugs change the antibiotic duration? For example, some surgeons love to extend for things like Pseudomonas.
It's not clear. I think it's not clear. And I think the problem is a lot of the shorter is better. One would have to go into the sub-analyses to see the specific microbiology and see if there's subgroups. But in general, those studies would be underpowered for clear subgroup analyses. And it's sort of like Aviva, where it's sort of a broad picture that paints a suggestion that this should work. But again, the shorter is better studies. Most of them are not nearly as big as Aviva was. So I think it's harder to do a clear subgroup analysis. So again, I can't answer it. I'm not 100% sure. And I'd have to look at the sub-analyses and sort of read those squinting one's eyes if there's individualized data based on the organisms that were isolated.
Sure. I think we could probably turn it around on them and say, there's no good evidence that you need to extend, to make the burden of proof the other direction. Obviously, the ones like Pseudomonas often get a bad rep because they can be very difficult to treat. So that's obviously confounder as well. They may have high MICs or difficult drugs and that. But I mean, assuming you've got a very susceptible Pseudomonas, I don't think there'd be good evidence to extend it. But as you said, it's really, I think the burden should be the other way. You know, if there is a good reason to extend, then let's see it from the trials. It's hard at the best of times that you get ages and ages of antibiotic treatment, as you rightly say. And nice to see that the newer guidelines as well have kind of also come online with the idea that if you really do chop off all the osteomyelitis, you know, your requirements for antibiotics are little to none, which is good to see.
I think if the one take home would be that the more one samples, the better one can apply all of this to our patients. I don't think we sample enough. And so we're often shooting in the dark. But I think if you had samples, if we send off clean and dirty margins from amputations, you send it osteomyelitis of bone for sort of microbiology and histology, these things correlate and they really can improve how you apply this, because a lot of this needs data. And I think the problem is often we're stuck in the dark if you don't have the data. And it just comes to liaising with the your surgical colleagues. And again, just as a matter of more it was almost funny in a sense, that second state-of-the-art review, there's an entire page of a big review article dedicated towards improving the interactions with your colleagues, specifically the surgical colleagues. So it's not necessarily a problem we only have here, but how to really address that where you are butting heads, how to deal with it, and just the importance of both of you being on the same team for the patient's benefit. So it was just interesting, an entire page in that second article that I showed at the beginning, just to that issue, how to really liaise with your colleagues, your surgical colleagues, to make the best outcome for the patient.
That's going to be some good reading, hopefully they graded the evidence. Cool. I was just looking through some of the other things. Yeah, I think you covered really nicely. So someone's asked about the sort of the organisms, but you covered really nicely the sort of shift between gram positives really being your focus with the milder infections to having to think considerably about gram negatives in the more severe infections, because I think that's also something that's not often well done. And then is a question someone's WhatsApped me about the oral versus IV. You did obviously go into it. I guess, I mean, would it be fair to say, do you think that for the highly bioavailable ones, it doesn't matter, right? I mean, as in, you know, whether it's oral or IV, it should be equivalent as long as they're hemodynamically stable, etc. I guess the question is more for the oral options that not so highly bioavailable, where you're legitimately getting slightly lower levels, right? Or what do you think?
Yeah, I think that there's, again, one of the things that's why I wanted to just stress, it would be nice to get the raw data from Aviva, for example, or someone to come and actually look how many of those were diabetic foot infections, because again, I'm sure a big subset were. The problem is it's not clear which ones they were, and to do a sort of sub-analysis on that group. But I mean, logic would dictate that you can extrapolate one to the other, assuming you've addressed the overlying wound healing, vascular components, and obviously paying cognizance to the choice of regimen with good bioavailability. So yeah, I would feel comfortable in a patient who's settling, and certainly, I mean, decreasing their length of stay, etc., and certainly in mild infections, to use those regimens that we know are well established, and have good track records as orally bioavailable drugs for osteomyelitis in general.
Yeah, well put.